Hi, my name is Afsar Ali and I will be teaching about third nerve palsies. The teaching is designed for doctors, junior doctors, orthoptists, optometrists, anybody particularly who comes across patients with double vision, and it is aimed at making it more efficient at diagnosing third nerve palsy. Now, the other thing to mention here is that I'll be outlining ocular movements, cover test, Hess chart, tests particularly that or augment the diagnosis, and tips and tricks that are there to help you to reach your diagnosis of a third nerve palsy. I think it's nice to start with some interesting facts. So there are 12 cranial nerves, and the 12 cranial nerves innervate 600 muscles within the body. Now, nerve number 2, 3, 4, and 6 are actually dedicated to the eye. That's 33% of the total cranial nerves are actually dedicated for the eye alone. You can just see here alone how important the eye is. There are 6 extraocular muscles within the eye. Nerve number 6 supplies to the lateral rectus muscle, so that's one muscle. Nerve number 4 supplies to the superior oblique muscle, that's one muscle again. And the big chief here is the third nerve, because the third nerve supplies to 4 of the muscles. Those are the superior rectus, inferior oblique, medial rectus, inferior rectus. It also supplies the levator muscle and the ciliary muscle. So when I was a student, I found it very difficult to comprehend this reading textbooks. I'm a visual learner and I always found it better to actually see the objects in front of me. So here it is for you. The third nerve actually supplies the superior rectus, which is used for looking up. It also supplies the medial rectus, which is here, and that moves the eye inwards. It also supplies the inferior rectus muscle, just here. Okay, that makes the eye look down. There's another muscle, it's the oblique muscle, which is the inferior oblique muscle. And the oblique muscles actually move at an angle. So if you were to look up there, the eyes would just go like that. And those are the 4 muscles. When a patient comes in through A&E and complaining of double vision, there's usually 3 nerves that can cause double vision. It's the third nerve, 4th nerve, or the 6th nerve. Now, if a patient complains of horizontal diplopia, then it's usually, and in the distance, usually that's 6th nerve, so you can eliminate that instantly. But our patient here, she's complaining about vertical double vision. So if a patient is complaining of vertical double vision, now you know that there's only 2 particular nerves that can cause vertical double vision. That's 4th nerve and a 3rd nerve. Now at this point, when you're trying to determine whether this is a 3rd nerve or 4th nerve, 3rd nerve is usually affected by a ptosis. So if a patient has a ptosis included with the vertical, that's actually solved your diagnosis instantly. You could reach a diagnosis instantly. So what you do is you observe. As soon as the patient says to you, I've got vertical double vision, look out, observe if the patient's got ptosis. So in this case here, so if you look at the initial observation of a third nerve palsy, this is a left third nerve palsy, what you'll notice is that there's a ptosis in the left eye. And not just that, the eye also looks a little bit down and out. That's the key point to remember, that it's down and out. But ptosis also helps you to determine that this is probably a third nerve palsy. I'm going to do a cover test. Now, I would anticipate with the left third nerve, it should be down and out. So as soon as I cover the right eye, the left eye should move in a bit. And watch this, I've covered it and you can see it very slowly. And there, it moves in. And it lifts up very slightly. Now, it's very difficult to see it on the camera, but with the naked eye, you can actually see a little bit of lift, and that's where the word down and out comes from. So that's a typical sign. If you're trying to determine if a patient's got left third nerve, try and remember down and out, and the ptosis would give you a big clue as well here. We're going to do ocular movements, and it's going to be Levo version. Follow the light for me, please, the blue light. And that should be fine because the lateral rectus is in that position. There should be no problems here. This is the lateral rectus. Levo elevation, there should be some problems because this is a superior rectus that's innervated by the third nerve. So if you have a look here, it should be a little bit down. Now I'm going to cover this eye and it goes up a bit. Looking into lateral depression, sometimes you'll see problems, restriction there, but it looks fine. Now moving into the dextro position. Now I'm expecting a medial rectus restriction. So if you look, the left eye doesn't fully adduct. And can you see the right eye's gone completely there? Let's do it again. Let's show you 3 times. There, you can see the right eye moving out to the right, but the left eye didn't follow. And the third time, and watch this, there, it just doesn't. I covered the right eye so that I can see if the left eye adducts fully. However, it didn't adduct fully. There's restrictions there. 2, 3. Okay, so now we're going to go into dextro elevation. If you have follow the light all the way up there. Now what you'll see with the patient's eyes, the right eye actually follows all the way up there, but the left eye does not. And that's the inferior oblique that's affected here. Okay, now we're going to move into dextro depression. So if you have a look there, dextro depression, there. Now you see the right eye actually moves down fully. The left eye, although it comes down, it's not adducting. And now the superior oblique operates in this direction. That's the 4th nerve. Now superior oblique would usually be fine, but because the medial rectus is affected, you're not seeing the adduction as well with it. Now we're going to go into elevation, and you'll see the right eye moves up, but the left eye doesn't. And the reason is the muscle that's affected there would be the superior rectus and the inferior oblique. So if you have a look here, there it moves up. Now it doesn't have to be necessarily both. It could be one of the muscles affected there. And if you wanted an augmentation of that, then it's good to do a head. Now we're going to move into depression, and again have a look here. See the right eye moves down, but the left eye doesn't, and that's because of restrictions of the inferior rectus here. Previously I mentioned that you could see the left eye turning in, but it's difficult to see the left eye coming up, okay, in down and out. But one of the easier ways to do it is you actually correct the horizontal, and I managed to correct it earlier, so it's 20 diopters base in. Now you'll see the vertical. Okay, I'm just looking at the camera. Yeah, so you can see the vertical now when I do that. There's the left eye coming up, right eye coming down. Every time I move the cover, left eye comes up and the right eye comes down. So now you can see the vertical. She probably needs a bit more horizontal correction. So let's take it to 30. That's 30. That's 35. And that's 40. So there. So it's about there that you can actually see. And then you can correct the vertical. So now you know that this left eye was actually exotropic and hypotropic. Okay, so the patient's looking at the car and she's corrected for the horizontal. I've got her to hold the horizontal prism, which is 40 diopters. And now I'll correct the vertical. And I was looking at it earlier, it's around 8 diopters. See, there you go. Now you don't see any movements there on alternate cover test. So alternate cover test helps you to determine the maximum angle of a squint. And then you, there, so it's overcorrected there. Keep looking at the car. That's it. Okay. So now, when you correct the patient, you'll see the stabilization. The eye does not, now particularly look at the right eye. It doesn't move as much. Yes, there's a very little amount of movement, but she's overcorrected slightly on the horizontal there. So you take the prism before that, all right? But just to show you that when you actually use your prisms to measure the angle, eventually you won't see as much movement. So it's the left eye you should look at particularly. All right. For the Hess chart comprises of 2 fields, the inner fields with a cross that looks like a window and the outer field. Having a look there, this is the inner field and there's the cross that makes it look like a window and then the outer field. And if you only see the window, that means the outer field is so large that it actually goes off the radar. Now, with a left third nerve palsy, you would see a smaller field, and on the right eye, you'll actually see an expanded field. So what that means is that most of the muscles are underacting. Most of the muscles are not working. For example, the medial rectus is not working here. And this is why, according to Herring's law, you're going to get overaction, because remember, both eyes are still getting this same amount of innervation. Now, if this is underacting, then innervation is increased, and the same innervation is also given to this side, which makes it overact. The key thing to remember with a third nerve palsy, the affected eye is always smaller because most of the muscles are underacting, and this is why the field is far more contracted. The opposite eye will overact, and it will always be expanded. So this is a left third nerve palsy. The other thing to remember, key thing, is that it's down and out. Even if you forget everything else, remember the word down and out. So if you have a look at the middle, this is where it should be, but it's actually down and out. And if you can remember that, along with that you get a contracted field, an expansion, you're on the right track to diagnosing a left third nerve palsy. Now, here is an example of a right third nerve palsy. Here on the right side, you can see that this is the outer field and the inner field. So this outer field should actually be here. Now all of that top bit should be there. The left side should be here, down here, there. But you can see that it is significantly and drastically contracted because most of the muscles in the third nerve are actually not working properly. Here, the medial rectus, the inferior rectus, the superior rectus, and the inferior oblique. And this is why the whole field is contracted, and you can see both of those fields. Likewise, on the other side, you can actually see just the inner field, because what happens, again, according to Herring's law, when a muscle is not working, extra innervation is supplied to that eye, but that extra innervation is also supplied to the normal eye, which makes it overact. And this is why you can't see the outer field. It's actually gone off the scale. However, you can see the inner scale. And I mentioned to you the left third nerve palsy. I've shown you that the contracted field was on the left side, but here, because it's a right third nerve palsy, on this example I want to show you that the right field is actually contracted in the right third nerve, and then you'll get a larger field. So always look out for that you'll have a smaller field and a very large field on the other side. And then again, the key point to note is that this is your middle point. That should be here, so it's down and out. So always remember that, because one of the key things I want you to take home is that a third nerve is usually down and out, and it's contracted field. Okay, so this is the Hess chart, and this is an imperative piece of instrument to determine the third nerve palsies. The patient, when the patient sits, okay, the eyes are dissociated. So the left part looks at the grid, and the right eye where they project what they see. And when they project what they see, this is when we can actually work out if the muscles are overacting or underacting. So I'm going to point to that spot there. If you can point to the same spot, and we switch the lights on, and you'll see that there's a difference. Okay, her eyes are out a little bit. That one. And again, you can see the difference there. So her eyes are down and out. One now. And you can see it's again down and out. Today we have our associate specialist. He is our VR surgeon, very experienced, Mr. Manish Kunda, who will be speaking about the anatomy of the third
Basically,
nerve.
third nerve, regarding the anatomy, we'll focus mostly on the lesions and anatomical lesions. Nuclear lesions are there, but we will not concentrate more on that. We will concentrate on the basilar part of the third nerve, which is when it exits from the pons and midbrain. The most common lesion being aneurysm of the posterior communicating artery, causing isolated third nerve palsy. Other causes can be because of head trauma. So if you see a person with isolated third nerve palsy with pain, that is one of the things which you need to look at. The next part is the intracavernous part. Intracavernous part can be linked with multiple nerves involvement, but the most common causes being diabetes, pituitary problems, and miscellaneous causes like infection, caroticocavernous fistula, etc. Then the last part is the intraorbital part. This is the place where you can divide the lesions as surgical lesions and medical lesions. Reason being, the pupillomotor fibers are on the superficial part of the third nerve, and when you get something impinging on the nerve, that becomes a surgical cause. Otherwise, it's a medical causes. Medical causes can be diabetes, hypertension, etc.